The FDA has approved Acalabrutinib for mantle cell lymphoma, but in point of fact, it is the subject of several dozen trials in a variety of settings, either alone or in combination, such as hematologic malignancies, solid tumors, and even rheumatoid arthritis. We are here to discuss its use in patients with Waldenström's Macroglobulinemia, and to do that, I am with Dr. Roger Owen, who is from St. James University Hospital in Leeds in the United Kingdom.
Well, Acalabrutinib is a second-generation inhibitor of Bruton tyrosine kinase, and as we're aware, that's a key signaling molecule in B cells, and it's activated in pretty much every Waldenström's patient as a consequence of acquiring the MYD88 mutation. So clearly a central pathological event in the disease, and an obvious target for us to look at therapeutically.
So you just presented some phase 2 data. So what have you found so far?
Yeah, that's correct. This was the first presentation of an international study looking at single-agent Acalabrutinib in patients with treatment-naïve and relapsed refractory disease. And we found exceptional response rates, overall response rates in excess of 90%, so those are minor responses or better. Major responses, i.e. partial responses or better, were seen in approximately 80% of patients, and there's no real difference between treatment-naïve and relapsed refractory patients.
Which is important to know.
Absolutely.
Now, in terms of what's next after this, are you going to expand this particular phase 2, or is a phase 3 underway?
The next step for this is, I think we've got some additional work on this particular study, so we're still needing to expand our data in terms of the impact of genomics on outcome. We still have patients in follow-up because we've still yet to achieve the median in terms of progression, so we know that the efficacy outcomes here are excellent, and we currently have in excess of 70% of patients still on drug with a median follow-up of 28 months.
And limited toxicity, too, is probably what we should notice.
Yeah, the tox profile is very good. There are some toxicities which we would recognise for this class of drugs, such as bruising and bleeding. About half of patients get some minor bruising and bleeding. We've not seen too much in the way of major bleeding events, and we've had no patients stop treatment because of bleeding. The most characteristic adverse event for this patient is headache, and these patients do seem to get headache early on in treatment. This is typically low-grade, self-limiting, and interesting, appears to be caffeine responsive. We've got some relatively limited hematological toxicity and limited GI toxicity, so I think it's a pretty safe drug.
I mean, besides more time just to get an idea of the progression-free survival, and the fact that now you know that there is no real difference between naive and relapsed refractory, what other questions need to be answered at this point?
So clearly I think we need to answer a range of things, really. One, there's certainly data from Ibrutinib that seems to imply that the tumour genotype may impact outcome, and that maybe different approaches are required in patients with CXCR4 mutations in addition to the MYD88 mutations, and we need to look at that in the context of Acalabrutinib. And I guess the question here is, can we bring this up front for patients in whom one would normally consider chemoimmunotherapy? So I guess we really need to be scheduling probably conventional phase 3 studies with that in mind, and we'd certainly need to do that in order to gain approval for that approach, certainly in Europe.
But at this time, you seem to be pretty optimistic?
Oh, for sure. Yeah, I think this is a game changer. These drugs are, clearly targeting the underlying biology of the disease, and it's a real paradigm shift in our management of these patients.